I just want to take a second and talk about scheduling a little bit, so if we can. Just remind you there's no changes or anything, but this is April 3rd, the schedule on page 6. Today, of course, is April 3rd. Next week will be our last lecture, April 10th. We got 2 weeks left. How could you have a Tuesday without me? And then exam 3 will be 2 weeks from today. So April 17th will be test 3. I'll talk about it next week as we finish up. And then the final exam is, of course, I sent it out to all the remote. I think I did. Or if I didn't, I will today. Sent it out to the remote faculty for administration and for us here. I see on Ed's schedule, we are scheduled for the final on May 1st. Is that still on, or do you know?
It is.
It's still
8 o'clock.
8 o'clock. Okay. So 8 o'clock in the morning, May 1st, for you in this room. That'll be the final time. So again, next week we'll have class. The week after, test 3. That'll be 17th. And then 2 weeks from then, May 1st, will be the final exam for you here. For the remote sites, of course, as I said, I send it out. And you could schedule it with your respective faculty. I know several of the programs like to do both test 3 and the final on the same day. Get it over with. Others wait, spread it out. So it's up to you, whatever you think works best for you. Okay, so second thing. I want to go to my webpage. So this is my web page, and I could go back, but I won't. But this is kpsan.org, and in the upper right-hand corner, of course, you click the Moodle. I'm going to go through it all. I think everybody knows how to do it by now. At the end of the second class. I hope you've been on the website. There it is. Okay, I'm up to this Moodle login. And it'll ask you to just log in as a guest, which I already did, and go to my resources. And what I'm trying to get at is if you go to the videos and look at, I picked out this class now, Farm 2, Spring of 2018, and you look, Clinton has media site videos, and he now has my YouTube channel. So, yeah, I know, it's scary, huh? You know me. There's my YouTube channel. For Farm 2, and here's all the lectures, and now there's, last couple he'll put up when they finish today and next week. But he's done all my Farm 1 and Farm 2 class onto this YouTube channel, which will be available forever. At least till I can take it down. A couple years I'll leave it up. So the nice thing about that is, of course, you can view it anywhere. On your phone, on your television at home, and you have nothing to do on Friday night. You make a bowl of popcorn, grab a beer, sit down and enjoy it with the whole family, entire family. Kids at home. A farm video. So anyways, I just want to let you know they are available now on YouTube, which opens the accessibility to literally worldwide 24/7. Alright, enough of that. Let's go to page 215. Page 215. And to backtrack a little bit to the last time we met, that was 2 weeks ago. and we finished discussing hypertension. And so maybe to backtrack or summarize a little bit, we mentioned that hypertension is a risk factor, but a minor risk factor for surgery. And we can control the blood pressure and so on with a multitude of drugs available to us. And when somebody comes to surgery with a history of hypertension, obviously we take their blood pressure in the PACU or pre-op area. If the blood pressure is a little bit high, make sure that they've taken their medications. There is a little bit of controversy about the ACE inhibitors and the ARBs. Many people feel you should withhold them just the morning of surgery alone. Other people give them. There's no right or wrong way as of yet. But other than that, all antihypertensive medication should be given prior to surgery to help keep the pressure down. Take the patient back, put them to sleep. I don't have to talk to you about keeping the patient's blood pressures low during the case. Many ways we can do that, and you all know. What we stressed or talked about was post-operatively. When you wake the patient up, you're getting ready to take them to PACU, that's when we generally have the biggest shoot in blood pressure up and have to go ahead and chase it with some drugs. Some non-pharmacological things you can do, of course, are to make sure the patient is kept warm and doesn't shiver, make their analgesic and pain-free that help keep the pressure down. Have oxygen on if that's appropriate. They sit the head of the bed up a little bit if that's appropriate, and you can do that. That helps as well. And then give whatever the appropriate medication is. And on page 215, we went through some of the IV preparations. We can use an anesthesia to chase blood pressure down. And the most useful one, I think everyone would agree in, is labetalol, and that's listed first. And so giving 5 to 10 milligrams of labetalol at a time, titrating it in, waiting for a minute or two between doses, and titrate the patient's pressure down as you turn off the gas and wake the patient back up. And that can lead to a nice smooth recovery. Other choices, we talked about looking at the heart rate and the hypertension and tachycardia. Labetalol was the best choice. If the patient has hypertension and bradycardia, or slow heart rate, and you're hesitant to use a beta blocker because it'll make the heart rate even lower, then the other option was to use hydralazine. Hydralazine is a, quote, direct vasodilator. Works by opening potassium channels in vessels, which causes vasodilation. And you can increment that in as well in 10-minute periods, so 10 to 20 milligrams at a time. 10 is probably better. And that can be used to treat patients' hypertension as well if their heart rate is a little bit slow. Esmolol was also used by some people. Again, I don't think it's the best choice. It's not a wrong choice. It's just that because it vasoconstricts, labetalol is probably a better choice because you're better off vasodilating somebody, make their pressure go down rather than vasoconstricting. But it will work, and it's very titratable, as you know. I think everybody's had some experience with it. And there's the dose and so on page 215. We went through the difference, which I'm going to ask you in test 3. What's the difference between esmolol and labetalol? And here's the differences. Labetalol is a beta blocker. Esmolol is a beta blocker. Labetalol, however, is also an alpha blocker. So labetalol produces vasodilation. Esmolol produces vasoconstriction. Esmolol's short duration of action as a result of rapid hydrolysis into plasma by non-specific esterase enzymes, RBC esterase. Now there's other medications as well listed that can be used to drop blood pressure, but they're more of an infusion where somebody's going to have to be in the hospital and put an A-line in, like nitroprusside or nitroglycerin or something like that. And of course you're all familiar with those drugs. I don't think I have to beat them to death. Although I did talk a little bit about nipride, and if you want to go 2 pages previous to page 213, now down here in the camera, we went through a little bit of the pharmacology of nipride. There it is on the screen. And the nipride is comprised of 5 cyanide molecules in a nitro group. When it's metabolized, when it's given IV in the blood, it interacts with hemoglobin, takes an electron from hemoglobin, becomes supercharged and breaks open, releases the 5 cyanides, and in a perfect world, the cyanide scavenging ability of the body will be able to get rid of those cyanides safely. The way it does it is the cyanides are taken to the liver. They're combined with thiosulfate to form thiocyanate, and that's eliminated in the kidneys. If the monocyanide exceeds the ability to scavenge it as rapidly as it's being produced, then you can get cyanide poisoning. Cyanide poisoning comes from the fact that it interrupts the cytochrome oxidase electron chain, makes it so that the tissues can't burn oxygen, and the patients become hypoxic, tissue hypoxia, and they die. If you get that severe enough, they can of course die. Cyanide gas is very lethal because it just overwhelms the human body and it can't keep up with detoxifying the cyanide. So if you see industrial accidents, they'll occasionally have cyanide gas and people die right away. A lot of fires produce cyanide in the fire that's burning whatever substances, and they can get exposed that way too. Treatment on the next page, 214, is very standard. No matter what the cyanide poisoning is from, the treatment is to, of course, stop the infusion if it's a nitride-induced problem, to give sodium nitrate, sodium thiosulfate, oxygen, and so on. There's the treatment there on page 214. So I think that's kind of where we left off the last time. And if anybody has any questions, I'd be glad to go through them. But if not, then I'd like to move on to our topic for the day, and that is angina. So let's go to page 2. Right here. Page 224. We've been through arrhythmias, we've been through hypertension, third out of the 4 big cardiac diseases, the 4th being heart failure, we'll talk about next week. The 3rd being angina. And angina is certainly one of the most common, if not the most common, cardiac disease. And in anesthesia, we run into people with all forms of, all severities. From mild, they're not being treated, they don't even know they have it, to patients who are being treated for chest pain and angina and so on, to previous MI patients, all the way up to 5-vessel disease that's so bad you got to have a cabbage. And we see them in the heart room. So we see patients on all scales of mild, moderate, and severe coronary artery disease, and certainly it's something we run into on a daily, if not every other day basis. Now, I'm going to go off on a tangent for a minute. My training as a pharmacologist in graduate school was treatment of angina. So this is the area I got my degree from, and we would be harassed by my classmates because they said we had the easiest disease to treat. Because this is it. Either you increase supply of blood to the heart or you decrease cardiac demand. That's the only way you can treat angina. So every drug does one or the other, or maybe both if you get lucky. So gee, I wonder how this drug is going to work. I don't know. Is it going to make more blood flow to the heart? No, that'll work. Is it going to make the heart not beat as hard for any given situation? That'll work. That's the only two mechanisms you can have. Now, I say that semi-kiddingly, but it's pretty much probably true. And angina is a unique disease in that the drug treatment is a little bit different. Let's talk about it a little bit. Definition, I'm on page 224. I certainly won't read this all, but I do want to highlight a few things. Ischemic heart disease is most commonly caused obstruction or stenosis of one or more of the coronary arteries. It can lead to mismatches where you get an MI or whatever. We'll talk about that in detail. A chest pain, which can be caused by various conditions that can originate from the heart, may be ischemic or non-ischemic, and may not be related to coronary artery disease. It's currently estimated 17 million Americans have CAD. 10 million of them are having angina, and those are symptomatic, and 8 million plus have had an MI. So that's a lot of people. You're going to see this in a routine daily basis. I think probably hypertension, CAD, and diabetes are probably the three most common things we run into in patients coming for surgery. The economic burden of ischemic heart disease in the U.S. in 2010 is estimated at $177 billion. So it's a lot of expense. Treating, doing heart surgery, doing PCAs, doing angioplasties, etc., etc. Estimate the risk of coronary artery disease, MI, and angina among the 10 million Americans suffering from obstructive sleep apnea is 4.5 times higher because of the sleep apnea. On the next page, mechanisms for chest pain. Ischemia promotes the release of active substances such as adenosine, bradykinin, lipoxygenase byproducts, and protons that activate chemosensitive and mechanosensitive receptors, widely expressed as capsaicin-sensitive nerves in the cardiovascular system. So the byproducts of ischemia will stimulate the receptors in the heart to produce pain. That's supposed to let you know that you got a problem in the heart, and go ahead and fix it. The signals are transmitted for the upper fifth sympathetic ganglia, thoracic spinal cord, etc. These interconnections explain the various facets of the presentation of angina pain. Now you could stop somebody on the street and they can explain to you what everybody knows what angina is, right? Maybe not exactly, but they certainly know it means chest pain and shortness of breath and so on and so forth. So anyways, let's take a look at this. Clinical manifestation. Angina has 4 cardinal clinical features. The character of the discomfort, what kind of chest pain is it? Its site, its distribution, its provocation, and its duration. The character of anginal discomfort is typically described as pressure, invasive feeling of strangling or anxiety. You got pressure in your chest, you can't relieve it, you feel like you can't get your breath, it makes you nervous. Other adjectives frequently used to describe the discomfort include heavy, squeezing, constricting, vice-like, suffocating, crushing. You get the point. That pretty much would, let me know what was going on if I heard that. In some patients, the quality of the sensation is more vague, and often in women who have more vague symptoms than men do. These patients may describe the discomfort as a burning sensation in the mid-epigastrium or an uncomfortable numb sensation. That's why the patients occasionally will mistake it for heartburn. You've heard stories their whole nursing career taking care of patients where, I don't know, I had heartburn, I didn't know it was then I ended up in the ER and, so on and so forth. So sometimes they mistake it for that. Angina equivalents such as dyspnea, fatigue, lightheadedness, or dizziness may likewise be described. Angina is most associated with the characteristics of chest pain. Pain usually builds up rapidly within 30 seconds and disappears within about 5 to 10 minutes. Now that's very important. I'm going to show you some graphs and figures about that. More promptly when nitroglycerin is used. The typical duration of an episode of angina is brief, usually under 15 minutes. Chest discomfort that persists for more than 15 minutes automatically triggers what? 911. Call an ambulance and get to the hospital, you're having an MI. So, angina and an MI are the same thing. There's a mismatch in the supply and demand of the heart. The heart's demanding more oxygen than you're supplying it. If it occurs and lasts 5 or 10 minutes, we call it angina. If it lasts more than 15 minutes, we say you're having a heart attack, an MI. They're all the same thing. Physiologically, it's the same thing. It's just how long does it last? If it's lasting more than 15 minutes, then that's an issue. Chest discomfort that persists for more than 15 to 20 minutes, especially at rest, is likely to represent acute coronary syndrome or an MI. They talk about the different kinds of pain and so forth, and I won't beat that to death. I think you all know that as nurses. So let's take a look at one of these graphs. I want to go to page, that's right here. I want to go to page 236. I'm going to go on the camera. This is from a dog lab study, and it pretty much says it all. That's why I put it up here. What they're looking at is they've occluded the LAD, the left anterior descending coronary artery, the main coronary artery to the left ventricle, and cut off the supply. And then how long is the duration? From 40 minutes, 3 hours, 6 hours on the x-axis. And what percent of the myocardium is salvageable after that amount of ischemia? In other words, when the blood supply gets started again, you get reperfusion, things are back to normal. How much damage to the heart will there be, if any? Well, you look, and 100% of the heart is salvageable. In other words, it'll go back to normal, without any damage. For the first, take a look at that little green dot. What do you say that is? I'd say 15 minutes, right? So after, within the first 15 minutes, if you can get the supply of blood back in the heart normally, or more likely, depress the heart so it doesn't need as much oxygen, then all the myocardial tissue that's been at risk will recover. If you don't, and you allow the occlusion to continue, then you can see very rapidly, here's 40 minutes, you've lost over almost 40% of the tissue. Here's 3 hours, only about 10% salvageable. well, you're going to be dead by then. And here's 6 hours as well. So you get the point. The point is, there's a certain window or period where the cells are salvageable, and if you can get blood supply to be reintroduced within that 15-minute window, you can save the cells. Other than that, you start to get cell death. Yeah. This is the same thing. This is just another drawing from another study. They're looking at the benefit of reperfusion, and the time to reperfusion agent. So this is giving somebody TPA or one of the coronary drugs, getting blood flow back in. Since most MIs nowadays are known to be thrombus broken off and clotting up an artery, if they can get rid of the thrombus and get blood flow, you can have a good outcome. So maximal benefit is if it happens within the first hour, and then you can see as the hours pass, less and less benefit will come from getting blood back because the tissues are already dead, cells are dead. Now, let me go to, let's talk about just some general types. This is on page 239. Oh, here. I'm sorry, 238. Page 238. And this is real simple, as I said. All the anti-angiogenic drugs are going to do one or two things, or maybe all both, if you're lucky. They're going to decrease the demand of the heart, or they're going to increase the supply. So what they're trying to show here is, here's your normal supply and demand balance. You got enough supply to meet the demand, everything's even. The scale is even. The scale is tipped if your demand exceeds your supply. So in this case in the middle line there, the patient's obviously having angina. And then finally, in the bottom, with giving drugs, you want to get things back to normal. Then you want to decrease demand, or you can increase supply. Now, most anti-angiogenic drugs work by decreasing cardiac demand. And it's kind of common sense. You already know this. You don't have to write it down or anything. But if you've got plugged up coronary arteries, I can dilate them with drugs from now till who knows when. And they're still plugged up. So it's hard to get blood to flow through a plugged up pipe. Whether you make the pipe bigger, it's still plugged up. It's going to be hard to get blood to flow through it. So making more supply to the heart is hard to do physiologically, pharmacologically with a drug. But you can decrease demand pretty easily. So let's give a real stupid example. If I walk up 2 flights of stairs and my heart rate goes up to 115, and when it goes to 115, I start to feel, ooh, I get some chest pain. And I take a beta blocker, for example, depresses my heart, slows my heart rate. I walk up 2 flights of stairs, my heart rate goes up to 80, I don't have any angina. So I haven't the demand doesn't exceed the limited supply. So it's much easier to work on the demand side, make the heart depressed and not so hyperdynamic, than it is to work on the supply side. All right. So let's take a couple of them. Some definitions. This is the next page, page 239. There's many different types of angina, subtypes, and I do have some of them listed in here, and you're welcome to certainly look at it. But really, there's 3 main categories of angina, and that's what they're trying to show here. The first type, the most common type, most likely the type you'll see on a daily basis, is called stable angina. chronic stable or stable angina. Now, it seems odd. If somebody has angina, the word stable isn't what I would use to describe them. But what they mean in relation to angina is, if they say the patient's stable, that means predictable. That means over the short term, several years, this patient can predict when they're going to have chest pain. I can know when I go out to cut the lawn and I get halfway through the backyard, I better pop a nitro, I'm going to get chest pain. Or I go up so many flights of stairs, or whatever kind of physical activity is going to cause the patient trouble. It's pretty predictable and happens pretty much the same amount of cardiac work every time. And you see that they call that stable angina or exertional angina. And that's 80% of the patients. So 80%, see the little 80% stable underneath it there? 80% of the patients who have angina have what's known as stable angina. Now, it doesn't mean that it doesn't progress. Over years, what started as more mild forms, the patient becomes more medicated, the doses go up, they finally get to the point where the doses are not getting rid of the angina anymore, drugs are no longer working, lifestyle changes aren't working, and the patient becomes a candidate for surgery, or for PCA or surgery. So it is progressive, and you expect it to get worse as years go by, but in the short term, in many ways, it's stable. That's about 80% of the people. Unstable angina, well, let's go to the bottom one, variant. Variant angina is about 5% of the patients. And variant angina is spasmodic angina. In the old days, we called it Prinzmetal's angina, after the doctor who described it. And that's about 5% of the patients, very small number. And what happens is, those people get angina without exertion. They're sitting in a chair reading a newspaper, and all of a sudden they get chest pain. They're lying in bed. Look at this one. When do you get chest pain? I'll show you on the next slide. So they're lying in bed sleeping. They wake up with chest pain. Weren't doing any exertion or anything. What happened? Well, they got spasms. And the patient's coronary arteries just spasm for no rhyme or reason. Nobody knows why. So they get spontaneous spasms of the coronaries, and that causes angina. And the third type in the middle here is unstable, and that's a combination of the first two. So people with unstable angina are the worst. Because now they have, first of all, fixed exertional angina and variant angina. They got both kinds. They get angina from exertion, and they get it from spasms. And that's about 15% of the patients. So exertional angina, they're trying to show in this little drawing, fixed lesion. What they mean is that there's plaque, there's hamburgers and french fries pounded over all those years, plugging up your pipes, and you see the lumen, where the red part is. Blood can't flow as well through it, so it's plugged up, and that's going to give you exertional angina. Spasm alone, see, clean arteries. These are the people who, oh, he was a marathoner. She was a marathoner. Oh, next thing you know, she had a heart attack and died. They do an autopsy and they got nice clean vessels. Didn't have any heart disease, lipid form. Obviously they had heart disease because they had an MI and died, but it's from a spasm. Then the middle people have both spasms and occlusion. So that's the broad category. Now, these types of angina can be subcategorized to crescendo. The angina starts small and builds up, gets worse, or decrescendo. There's all different subtypes, but these are the main types. Typical characteristics. Stable angina. Is it exercise induced? Yes, it always is. These are people who go and do exertion. They exercise, but they need any physical activity. And So get chest pain. Occurs at rest, not usually. Occasionally, night pain, occasionally with dreams. I want that dream. I gotta wake up in the middle of the night with chest pain because I'm so excited for my dream. That's a hell of a dream. And usually you see EKG segment, depression, although I'll show you stuff. Variant angina, is it exercise induced? Rarely. Occurs at rest? Yes. Clusters in the morning. Almost all of the variant angina episodes occur between 4 a.m. and 8 a.m. for reasons nobody knows. These are patients who get chest pain in the morning. Usually produces ST elevation. And then unstable angina because they have both types. They've got exertional, yes. Occurs at rest, yes. You get pain at night, yes. They get pain all the time. And they can have ST changes of any kind. So the first obvious thing, when you see a patient and they say they have angina or they're taking nitroglycerin or any other signs that they have coronary artery disease, the first question you need to say is, when do you get chest pain? I get it when I go to the gym. I get it when I cut the lawn. I get it when I yell at my husband. Whatever. You get excited. Something to do with exertion that's making you excited. If they get it at rest, sitting watching TV, reading a newspaper, sleeping, then chances are they may have variant angina rather than exertional. And the treatments are different, which we'll talk about. Okay? Now let's go to page 236. I'll show you this kind of neat thing. I'm sorry, 234. My mistake. 234. Now I know a lot of you deal with this because you're cardiac CTICU nurses, and you have to deal with this type of thing all the time. But basically what they're trying to show is the flow rate. You got ischemia of some kind here at the top. So let's figure out what kind. Working diagnosis. Supply-demand imbalance. Well, look at this vessel. No wonder they got a supply-demand imbalance. It's almost totally plugged. Look at all that yuck over there. Need to roto-rooter that baby up. So then, sorry about that. Do an EKG on them, you'll get ST segment depression. The biomarkers may have an increased biomarker levels. If they do some lab tests. The final diagnosis is unstable angina or non-STEMI angina. Or maybe if it went on too long, they have a non-Q wave MI. On the other side here, you notice these vessels aren't plugged up as much, but acute coronary syndrome, this person's having an MI. Is it partially occluded because they broke a plaque off and threw a clot, or fully occluded due to a thrombus? If you can get EKG, you'll see that in this, with partial blood flow, they'll have ST segment elevation will be absent. In this one, ST segment elevation is present. So for complete inclusion, you're going to get a STEMI situation. And finally, you can take a look at it going down, what type of MI they would show. So that's the different subtypes of angina that we'll talk about. Now let's go to page 226. Classifications. Various classifications have addressed the pathophysiology, diagnosis, severity, and prognosis of angina. This is page 226. After. The distinction between unstable and stable is based on a pattern of angina. Its frequency, its triggers, threshold, severity, duration, symptoms, and response to either arrest or nitroglycerin. Angina is considered stable when symptoms have not been changing recently. They rather are precipitated by a degree of effort that's reasonably predictable from day to day and is relieved by rest more rapidly by rest and nitroglycerin. Conversely, a lowering threshold to pain and progression in frequency evokes a diagnosis of unstable angina. Okay, let's take a break. Okay, let's go to page 226. Page 226. Oh, they'll figure out. Now, I just have a few things on there. This isn't really anesthesia related directly, but it does relate to us. This is a list of some of the blood tests that you use for diagnostics for ischemia. This lipid levels, inside of page 226. Then glucose, thyroid levels, hemoglobin A1C in diabetic patients, some cardiac markers, prothrombotic assessment, see if the patient's prone to clotting, and their homocysteine levels. These are common tests that are done way before they get to us. Now, page 228, the next page. This is the anesthesia part. Now here's the problem. Here's what goes on with anesthesia. And we'll come back to this, but I'll give you a little taste of it now. The problem is this. When you have somebody asleep, general anesthetic, you lose the symptoms a lot of times of what angina is going to cause. They're not going to say to you, I got chest pain, you're asleep. Diaphoresis, shortness of breath, well, you got them on rocuronium, paralyzed on a ventilator. You're not going to be able to see that. So a lot of the things that we look for, you would expect in a non-anesthetized patient, everyone else in the medicine, gets to talk to mostly awake people, then we lose a lot of that. So what do we have? Well, we got EKG changes, but most everybody will tell you the EKG changes are rather late, in the sense that ischemia has been going on for a while when you start to see changes in EKG. And secondly, because since we use mostly 3-lead EKG, we don't have, EKG mapping and all the extensive 12-lead kind of information. So we have much less to go on when you look for angina under anesthesia. Mostly ST changes and some vital signs changes, etc. So for many years, and I mean 25 years, people tried to come up with a way to kind of figure they might be having ischemia while they're asleep. Oh, and they had was a real trendy one for a while. It was rate pressure product, and took the patient's heart rate and multiplied it times their blood pressure, and you'd get a certain number, and then you wanted to keep them at that number, and it was a mess. It didn't work. But and I think now, well, we'll come back to it later. But anyways, take a look at this. This is page 228. Over the last 2 decades, numerous studies have explored the relationship between patients' hemodynamics and whether they're having ischemia or an MI. The strongest predictor is, surprise, surprise, tachycardia. So tachycardia is the thing that causes the most cardiac work, and it's going to be most predictive of somebody having angina. Now, if you want to go to page 231, there's a table on the top of page 231. Conditions detrimental to myocardial oxygen supply and demand. And I've been wearing this microphone without it being on. Don't get old. All right, so page 7, wow. Louder in the back. So page 231, the top table, conditions detrimental to myocardial oxygen balance. Well, decrease in oxygen supply to the heart, that's mostly not enough flow because of tachycardia. When the patient's heart, the coronary is filled during diastole, when the heart's at rest. So the faster the heart rate, the shorter the diastole time, the less supply to the heart. Hypotension, of course, if you don't have enough pressure to drive blood into the heart. Hypocapnia because of the vasoconstriction that comes with low CO2, and if somebody's having coronary artery spasms. A decreased oxygen content in the blood. That's not real likely, but it can occur if somebody's very anemic, hypoxia for whatever reason, and a reduced oxygen release from hemoglobin. Increased oxygen demand, look what's on that side too, the first word, tachycardia. So tachycardia hurts you on both sides. It decreases the supply of blood flow to the heart, and of course makes a higher demand. So because of an increase in preload, afterload, wall tension, etc. So tachycardia is not good. And as we have joked about several times, and you know from being in the OR, anesthesia people hate tachycardia. There's no good to come of it when the heart rate's fast. Something bad is happening. We try to find out what as soon as possible. It could be something minor, it could be something major, but it's not good. So let's take a look at page 228. Tachycardia is the strongest predictor of periop ischemia. Although traditionally, in a heart rate higher than 100 defines tachycardia, slower heart rates may result in ischemia too. If somebody has bad vessel disease, and their heart rate goes up to 90, maybe they could get ischemia. So in other words, the number 100 isn't magical. It's valid for most people, it's a mean, but some people with bad heart disease could even be slower. As described later, control of heart rate with beta blockers decreases the incidence of myocardial ischemia and infarction. Heart rate control lowers the incidence of perioperative MI, with the greatest benefit being achieved if the control is less than 70. If you can keep somebody's heart rate below 70, ooh, that's easier said than done a lot of times, then the chances of them having an event under anesthesia is pretty minimal. Though some have expressed concern about beta blockers causing intraoperative hypotension in patients with CAD, no evidence supports this contention. The POISE trial is a very famous study, demonstrated that acute beta blockade protocol was associated with hypotension and a higher rate of stroke with the drug metoprolol. During CABG, the vast majority of episodes of ischemia do not correlate with hemodynamic changes. Well, that's because the surgeon's sewing the vessels on the heart. That's a pretty abnormal situation. In the absence of tachycardia, hypotension is not associated with ischemia. So the take-home message from this is keep the heart rate slow. And we keep the heart rate slow by giving beta blockers. So the number one therapy for the treatment of anybody with angina is they're automatically put on a beta blocker. That's considered almost malpractice not to do that. So if somebody has any degree of CAD after cardiac testing and so on, then they're going to be put on a beta blocker. So you can say, what do beta blockers do? Well, they vasoconstrict, right? We've been through this a lot of times. Beta 2 receptors dilate vessels. Beta blockers therefore vasoconstrict. So if I told you the #1 prescribed drug for angina in the world, it's almost malpractice if you didn't give the patient this, is a drug that causes cardiac constriction. And that's true. You'd say, well, you're crazy. What do you mean? Well, what I mean is the beta blockers decrease demand so much, if you get your heart rate down to 50, 55, you're not going to get ischemia no matter what size vessels you have. Remember, as I mentioned, if you can dilate the vessels, a lot of times that doesn't really matter. Vascular tone, it's contributory, but not the main effect. So beta blockers are the #1 drugs for ischemia, period. Somebody has angina, they're going to take a beta blocker all the time, unless there's some absolute contraindication to giving them them. And the reason is because it decreases cardiac demand. Slows the heart, doesn't beat as hard, doesn't beat as fast, and the patient's not going to have ischemic events. So hopefully that makes sense. All right, let's go to the next page. These are the drugs. This is supposed to be pharmacology. Let's talk drugs. First of all, nitrates. Well, nitroglycerin is one of the mainstays for the treatment of angina and has been for decades, centuries. The nitrates are first-line therapy for acute attacks. So they're given if the patient feels an angina attack coming on, starting to have chest pain or whatever, then they, first of all, will take a nitroglycerin. Now, if you want to take a look at page 232, it's all marketing. They always come from Glendora. I get 5 phone calls a day from somebody in Glendora. There's never anyone there. I'm being traced by that person. Let's take a look at page 232. So this is an angina text. This is what they're trying to show or delineate. So whatever, first of all, there's some sort of effort. You went out and climbed the stairs, you cut the lawn, you did some kind of work, and all of a sudden, this is in a matter of seconds, you start to get ischemia. This is red area here.
Dr. Nicolai.
Oh, not showing. I'm sorry. Technology problems today. There you go. Diastolic and systolic dysfunction. Some EKG changes, but look at, dyspnea and EKG changes are a little bit later than some of the other symptoms. That's called the ischemic cascade. And that'll take seconds to minutes. Then all of a sudden they're going to have chest pain and EKG changes. That's when we see them under anesthesia, the EKG changes. But see, they've already been having issues for several seconds to minutes by the time we see them. Then you do one or two things. Sit down and rest. Most angina patients prefer to do that. Try to sit down, put your legs below your heart in a chair, catch your breath, and hope that it goes away. Most people who take nitroglycerin will try to avoid it like a plague. They don't like to have to take nitroglycerin. They take it if they have to because it can be life-saving, don't get me wrong. But it causes such a pounding headache, and at times makes it kind of get those muscle quivers, and you feel funny, and they just don't like the way they feel. But if they have to, they have to. So try to sit down and have the chest pain go away. Give it a minute or two. If nothing's happening, then the EKG is normal. If you want to take your nitroglycerin or not, recovery is starting here, and then full recovery is down here. It takes minutes to several hours to fully recover from that angina attack. The little period, several hours after you've had the attack, the heart is not functioning properly. They call it cardiac stunning. The heart is stunned. It's kind of in a daze, and it's going to take several hours to return to normal. So that's kind of a ischemic cascade description. And on the next page, page 233, these are how antiangials work. So let's start at the top and we'll go around clockwise. You can reduce heart rate. That's the best way to do it. And of course, drugs that do that are beta blockers, verapamil, calcium channel blockers. Some patients who can't take beta blockers can use those. And we need to reduce afterload by giving calcium blockers and nitrates. So you want to reduce heart rate, reduce preload, reduce afterload. Now, I think I'm gonna, where's my nitroglycerin now? Here it is. So this is what happens when you take nitroglycerin. Let's read this down the right side. When you get angina pain, discomfort or pressure, typically localized, I'm sorry, my mistake. Page 242. 242. My brain's not working today, I don't know why. You get an angina attack, chest pain, etc. There's insufficient supply of blood to the myocardium. The effects of nitrates. In stable angina, they dilate veins. So the main contributory action, I'm going to ask you on test 3. Why does nitroglycerin make your chest pain go away? The answer is because it dilates the veins in your legs. Venous dilation. See this area of the little figure? They're saying in stable angina, contributory effect, see where my cursor is? Dilation of veins. And if your legs are dependent to your heart, blood pools in your legs, you lower your preload, less load on the heart, and the chest pain goes away. Now you also get some dilation of the collateral vessels in your heart. So there is some microcirculation, vasodilation in the heart that can be helpful, but it's minor. Therefore, you got decreased O2 consumption. I'm coming down the drawing here. Reduce end-diastolic pressure, reduce wall stress, and your angina goes away. So that's the mechanism of action of nitroglycerin. Okay, back to page 229. So, first of all, drug therapy for angina. First thing is the nitrates. First line therapy for acute attacks. Secondly, beta blockers. Cornerstone therapy for chronic prophylaxis. Third class is calcium channel blockers. They're especially effective for variant angina. If you're having spasms, the calcium channel blockers help prevent them. course, antiplatelet drugs, aspirin and Plavix, can make your blood less likely to clot. Statins to lower your cholesterol. ACE inhibitors can be used especially in diabetics. And Renexa is used mostly in Europe, but is available in the US and that as an add-on drug to help with coronary flow. So those are the drug treatments for angina. If somebody comes to surgery and whatever drugs are on, make sure they take them. They stay on them up to the morning of surgery. Now, page 230. This is the basic classification for angina. And as with all classifications, it starts with mild and goes to more severe. In this case, almost everybody in the world uses what's called the Canadian classification for angina. There are some others, but they're all pretty much the same. Class 1 angina is angina that does not occur with ordinary physical activity, walking, climbing stairs, etc., but may occur with strenuous, rapid, and prolonged exertion. Class 2 is a slight limitation of activity, may occur with walking or climbing stairs after meals, in the cold, in the wind, under emotional stress, walking up hills, and so on and so forth. Class 3, there's a marked limitation of activity. Angina occurs after walking 1 or 2 blocks on the level or climbing 1 flight of stairs. That's pretty severe. And class 4 means you have angina at all situations, any kind of cardiac work, at rest, whatever, and you're on your way to open heart surgery. That's class 4. For the EKG on the bottom there, I put in there, and this is kind of standard stuff, ST segment elevation and depression, T-wave inversion, all 3 of those on the EKG, and you're familiar with this. If it's a transmural ischemia, you usually get ST elevation. Subendocardial with abnormal repolarization, you can get depression or T-wave inversion. Okay, page 235, I just put in there, and again, this isn't really anesthesia related, but it just kind of colors the picture fully. This is approach to pharmacotherapy in early hospital care in patients with acute coronary syndromes. They mention when they haven't hit the ER or the cardiac unit and they have a mismatch with supply and demand. Again, I'm on page 235. Administer oxygen, give analgesics, IV morphine is preferred. Give beta blockers and calcium channel blockers to decrease cardiac demand. If they have a clot and they threw a thrombus, then they can get antiplatelet and or anticoagulant therapy, or if they're going to get angioplasty, then that's a whole new ballgame. But then eventually statin therapy and ACE inhibitors will be given once they stabilize. Now, last time I talked about, well, let's go to page 243. Nitrates work, of course, by venous dilation. Some of the side effects, of course, are a result of that. So what are some of the side effects or contraindications to nitrates? Well, you get a drop in blood pressure because of the vasodilation. You get some headaches, dizziness, and palpitations, and many patients complain of that. And they'll try to rest and get rid of their chest pain before they pop a nitro. The only contraindications are is if your blood pressure is too low to begin with, you have to be careful giving blood pressure lowering medications. That's not too hard to figure out. Now, last week I did mention, and we went through this, I'm more than happy to do it again. Let's go to page 244. When you talk about beta blockers and the treatment of angina, there are different types of subtypes of beta blockers, and we went through this last week, or 2 weeks ago, I'm sorry. First of all, a non-selective beta blocker, and that's in the red here. These are beta subtypes. This is norepinephrine release on a beta 1 receptor. You get cardiac stimulation. Renin release from the kidneys is beta 1, and the burning of fat or lipolysis. Beta 2 receptors produce bronchodilation, vasodilation, and glycogenolysis. In other words, increase in blood sugar. If you give a beta blocker that's non-selective, it blocks beta 1 and, beta 2 effects, then you get the desired beta 1 effects, bradycardia, renin suppression, and reduced fatty acids. But you also get the undesirable side effects of bronchospasm, vasoconstriction, and lethargy. If you have one that's a little bit more selective for the heart only, it supposedly will have a less side effect profile. So you get the desired effects, bradycardia, renin suppression, etc., without as much bronchodilation, etc. Bronchoconstriction. So how do beta blockers get rid of angina? They get rid of angina by decreasing cardiac demand. That's it. You can say it all in one sentence. They make your heart rate slow. That's wonderful. That's what does it. How does nitroglycerin work as an anti-anginal drug? It's venous dilator. Now, if you have a beta blocker with ISA activity, we talked about a couple weeks ago, that means it's a partial agonist, not as strong a beta blocker. It's weak. Therefore, you get some beta blocker effects, but they're less. Less bradycardia, less bronchospasm, less everything. So they're still beta blockers, but they're poor, weak ones. If somebody has asthma and COPD, they may require that. And MSA activity, finally, and that was antiarrhythmic activity, and they're showing acebutolol and propranolol are the two that have decent antiarrhythmic properties. Now, let's talk about beta blockers in patients that are on them. And as I talked about a couple weeks ago, this is an area there's a lot of controversy because all the famous studies that were done out of the Netherlands were all made up. And they found out the scientist, who was a world-renowned cardiologist, spoke all over the world, famous, got all kinds of awards, published hundreds of studies on the effect of beta blockers in the heart, and he made it all up. It's unbelievable. So all the data that almost everybody's studies were based on were data provided by this guy, and nobody quite knows what to make of it now. So everything's kind of thrown into chaos. So This is from 2014, and I don't think it's changed very much, so I kind of took, this is from the Cardiology Society. This is ACC, is American College of Cardiology, and these are their guidelines. What do you do if a patient's on a beta blocker? Beta blockers are in the top 5 class of drugs prescribed in the world. So you're going to see people on beta blockers almost every day at work. So what does it mean to you? What do you do? Let's take a look. Maybe I can make this a little bigger. Page 249. All right. Anybody who's on a beta blocker, well, let's start with number 1. Beta blockers should be continued in patients undergoing surgery who've been on beta blockers chronically. So, as I said, if anybody's on a beta blocker, they have to stay on it. You get tremendous withdrawal symptoms if you stop taking them abruptly. So if somebody's on beta blockers for angina, and all of a sudden they stop taking them, they're going to have excess angina attacks. They have to stay on their beta blockers. It's reasonable for the management of beta blockers after surgery to be guided by clinical circumstances. How'd the patient do? They have any episodes, and you adjust it accordingly. In patients with high-risk MI or myocardial ischemia noted in pre-op testing, it may be reasonable to begin beta blockers. So the cardiologist who sees the patient a couple weeks before surgery, if they have significant disease and they're not on a beta blocker, they need to be put on a beta blocker. In patients with 3 or more cardiac risk index factors, such as diabetes, heart failure, CAD, renal problems, CVA, it may be reasonable to begin beta blockers prior to surgery. In patients with compelling long-term indication for beta blocker therapy, but no other risk factors, initiating beta blockers in a perioperative setting in an effort to reduce risk is of uncertain benefit. So unless they have symptoms, if you're giving beta blockers just to make somebody's heart rate slow, because you like slow heart rates, we all do, then it's probably not a good idea unless they have significant cardiac disease. It could be at greater risk. In patients who beta blocker therapy is initiated, it may be reasonable to begin beta blockers long enough in advance to assess safety. They say preferably more than 1 day. Most of the cardiologists say preferably about a week or 2 prior to surgery. Usually within 30 days prior to surgery. Starting the day before it is, right up to the edge. And then finally, beta blocker therapy should not be started on the day of surgery. So you can use beta blockers in somebody who hasn't had them yet. If their blood pressure is high, their heart rate's high, you feel it's appropriate treatment, sure, of course. They're talking about starting them and then keeping them on for 30 days after surgery. Don't do it. So that's kind of the standard therapy. So if somebody comes in, yes, question.
If someone didn't take their beta blocker at home and they came in, could you give them, if you don't have the option to give them the same dose orally, could you give them IV labetalol?
You can. The question was if they for whatever reason, skip their morning dose, oral pill dose. If you can get the pharmacy to send you the pill, that would be great. A lot of times, let's face it, we don't have that choice. Then yes, you can give them a little labetalol or something, during induction or during the case or during emergency. And that's a good idea. Okay, next page. I said this the last time. I put it in big letters here, page 250. Now we've talked about vasodilating drugs, and here's the thing to remember. Arterial dilator, that's hydralazine, meaning it reduces afterload. Venous dilator, that's nitroglycerin, which means it primarily reduces preload. And all other vasodilating agents will affect both arterial and venous vascular beds about the same. You can nitpick, there's one's a little more of this and that, but they're essentially the same. The two big outliers are hydralazine is arterial and nitroglycerin is venous. Okay, the next page, 251. What about the calcium blockers? And they actually have double benefit in that they depress the heart, so they decrease demand, but they also vasodilate the coronaries, so they can improve supply. So let's take a look at, and I'll go to my drawing. Here it is. Page 251. And you can see, I'll start here clockwise. They increase oxygen supply by having less spasm, less vasoconstriction, better collateral flow, etc. And they decrease oxygen demand by possibly affecting heart rate. They all don't do that. Most of them do. Decreasing preload and afterload and contractility. So they both decrease demand and increase supply. That's the calcium blockers. So I'll say it again. Nitroglycerin works by venous dilation, reducing preload. The beta blockers work by decreasing demand, slowing your heart rate and contractility. The calcium channel blockers, let me say it again. The calcium channel blockers, there, that's better. Decrease demand and increase supply. They do both. Now let me show you this little cute angina study. This is, let me get a little smaller. This is a study that I took from, forever, 1980s. I just like the bar graph in there. There's a ton of them. There's a million. You could have put them in there. I just did this one because of the colors. But this is somebody having a variant angina. So here's the thing. If somebody has spasmodic angina, that's 5% of the people with angina, small number, they have inadvertent spasms. If they're put on a beta blocker, sometimes it gets worse because it vasoconstricts. Beta blockers vasoconstrict. So the preferred drug for them are calcium channel blockers because they vasodilate. So don't get confused because you're going to read in my chapter, you're going to see in the literature and hear everywhere that beta blockers are not good for variant angina. It's the calcium channel blockers are the drugs of choice. This study will show it to you. This is a patient. They're looking at his variant angina, efficacy in variant angina, and this is page 252. This is the, on placebo, the number of attacks per week. Well, that's what, 14, 15 attacks per week? That's 2 a day. That's pretty much keeps you from having a life. You're going to have 2 angina attacks. How are you going to go to work? How are you going to drive a car? I'm not going to ride in your back seat. Hey, you okay up there? Well, watch that left turn. So, anyways, placebo group, and this is obviously patients put on a calcium blocker, and look at the efficacy. It's fabulous. They went from 14 or 15 attacks a week to 1. So that's, it's lifestyle-wise, it's life-saving. The patient can go out and have a life without all those issues. They do nitroglycerin pill counts. Pharmacists call them pill counts. And they see how fast you use your nitroglycerin. And that's a sign of how severe your disease is or is becoming or whatever. So they look at your prescription and see how fast you go through it. So this is nitroglycerin usage in tablets per week. And in the placebo group, they popped a nitro 10 times. So they had an attack 15 times a week. 5 of those they were able to just sit down and it went away. The other 10 they popped a nitro. And when they were put on a calcium blocker, they only had to take 1 a week. So much, much better. So the bottom line from this, and obviously the easiest thing to say, is that calcium channel blockers are especially effective for variant angina, the drugs of choice for variant angina, and the beta blockers are the drugs of choice for exertional or stable angina. Now the next page, 253, there's nitroglycerin and how does it work? And that's easy. The nitroglycerin, nitroprusside, all the nitro-containing drugs. The nitro group in the drug gets transferred into the cell. It causes the release of nitric oxide, NO. And nitric oxide is the body's vasodilator. It's the chemical that produces vasodilation. So when you raise the levels of nitric oxide, you produce vasodilation. And there's some of the nitroglycerin preparations. I think you're familiar with almost all of them. Sublingual, of course, dosing here. Buccal. They have sprays, tablets. Get everything. I don't know if I mentioned to you, the French drug company made nitroglycerin underwear. We're trying to figure out a way, because it only lasts about 15 or 20 minutes. So you can't use it as a prophylactic drug, in other words, for chronic treatment. You have to use it just for an acute attack. Otherwise, you'd have to take one every 20 minutes the rest of your life, which is stupid. So they tried to figure some way to get it absorbed better. So they made a underwear with the band of the underwear had nitroglycerin embedded in it. You put your underwear on and then you were fine. Didn't work. Anyways, you can see some of the common nitroglycerin drugs that are available, many of which you've given multiple times, and we'll leave it at that. So, on the next page is the statins, and I listed them there. And again, drugs you're familiar with. I think the statins have overtaken everything else as the #1 prescribed class of drug in the world. If you're a man over 40 years old and you're not on a statin, you need to get a new doctor. A lot of women now too. Okay, some drugs that can affect coagulation, and I put this in here, next page, 256. I'm almost done here, so I'm going to keep going and then I'll just let you out early. These are, and you're familiar with all these drugs. Anticoagulants, antiplatelet drugs, antifibrinolytics, and so on. But the reason I put this table on here is to talk about the herbals. I haven't really covered that, and you will get it in other lectures. But just learn the big three. See, garlic, ginger, and ginkgo. So when you think about herbal medicines and their possible effects when somebody comes to surgery or whatever, there are 3 herbal medicines that cause an anticoagulant effect and promote bleeding. And they're the 3 G's. They always mention them as the 3 G's. Garlic, ginger, and ginkgo. There's a lot of information on herbal medicines. They almost mean nothing. They have very little. The talk about them is worse than the actual patients taking them. And they always say, "Oh, watch out! Somebody's taking it. It's not going to cause any trouble." Just be careful of those three. Okay, the next page, 257, an ever so prominent issue nowadays, and getting more so as years pass, and more people get a stent put in, is what do you do when somebody comes to surgery and they've had stent procedure and they had a coronary stent put in. And so that's pretty simple. This is the kind of the standard wisdom from American College of Cardiology. There are some variations with different groups, American Heart Association, Europeans, the Japanese, whatever, but they're all basically the same. And here it is. If somebody has a stent, if they have an elective surgery with a high risk of perioperative bleeding, you should postpone the surgery until, if somebody has a drug-eluting stent, which almost everybody does nowadays, for 12 months. So you don't want to do surgery on somebody who's had a recent stent implantation. If you don't have to have it, it's purely elective for up to 12 months. The Europeans say 6 to 12 months, depending on the surgery. If it's something like a hip or a knee where somebody kind of wants it, it's not. It's elective, but it's a little bit more of an emergency. Then you can go maybe 6 to 12 months. Bare metal stents were the initial stents that people put in. This was back 20 years ago. There's, I'm sure, a couple old guys like me still running around. I don't have one, by the way. But I mean, my age, who've had a stent put in when they were originally started doing angioplasties. And they were bare metal stents. But there's not. They don't use them anymore, and the number of old guys is dwindling because they have coronary disease and they're dying. Second bullet, elective non-cardiac surgery is not recommended with somebody who's on double therapy. The thienopyridines is Plavix. So that's an antiplatelet drug. Of course, aspirin is antiplatelet as well. So if you have somebody who's had a stent, they're going to have dual antiplatelet therapy, DAT. It's as common as the common cold in cardiology. Everybody who has a stent gets put on DAT, dual antiplatelet therapy. That means aspirin and Plavix. And unless you can discontinue at least one of them, then elective non-cardiac surgery is not recommended for up to 12 months. Third bullet. When surgery can't be postponed and you have to interrupt the Plavix therapy, it's recommended that aspirin is still given. That you continue it throughout the perioperative period and then start up the Plavix again as soon as possible after surgery. So you're worried about bleeding. If somebody's on dual antiplatelet therapy, there's a potential for blood loss in certain procedures, and you can get rid of the Plavix for 48 hours. That's great. Keep them on the aspirin. Number 4 bullet, the antiplatelet or anticoagulant meds with short half-lives may be used in the periop period to kind of get them through surgery. They call it bridging, taking them off their regular medicines and bridge them to a temporary medicine, and then when they're through, bridge them off of the temporary medicine back to their regular medicine. Antiplatelet and anticoagulant medication with short half-lives may be used as periop bridging between discontinuation of antiplatelets and surgery. Evidence lacking in the use of warfarin, antithrombus, or glycoprotein 2B3A agents. Consideration should be given to the following patients. Finally, last, continuation of DAT beyond the recommended time frame in patients at high risk for stent thrombosis, or continuation of aspirin, periop in all patients with drug-eluting stents. So nowadays, you don't have to discontinue aspirin. Again, I mentioned I had surgery, as you know. took a day off last semester, and I had surgery on my wrist, and I take aspirin every day since I'm post-stroke, and the pre-op, it was a physician assistant, when I went for my pre-op, said, stop taking your aspirin. This was 7 days before surgery. I said, okay, and of course I didn't. If you can't stop bleeding in my wrist, for God's sakes, with a Bovie machine, I only had this big incision, So, I mean, it was obviously stupid. The chances of having a cardiac event are much higher than you bleeding to death in the middle of a wrist surgery. I mean, come on. So, it's to the point now where it's just routine. People have always said discontinue aspirin, so they still say it without even thinking that, unless it's, as I said before, a closed system surgery. In the eye, where it's any kind of bleeding can put pressure inside the eye and cause ischemia. In craniotomies, brain surgery, any amount of bleeding may be detrimental. And the third situation they always talk about is prostate surgery, because of the vascularity and the fact that prostates bleed like hell, and you're doing TURPs and all that. So in those types of surgeries, yes, there's an indication for continuation of the aspirin. Other than that, just let patients take it. It's not going to hurt. Okay, page 258. Here's some of the pre-op testing they do. I'm not going to go through all this, but these are common stress tests to evaluate angina, and you can see tests that you've sent patients to and interpreted and read the results from, and that's part of our routine nursing care. And you can kind of take a look at yourself. And finally, on the last page, 259, this is the current American College of Cardiology approach to the treatment of angina. They call it stepped care. So for mild, you just go on the first step, and if you got severe, you keep climbing the steps further. So number one, in general, history and physical exam to exclude something other than angina. And check risk factors if you have, access to the patient and they're in the hospital and they can have lab tests. Most of the time it's a luxury. Prophylactic drugs they may be on, aspirin, statins, ACE inhibitors. Make sure that they take their medicines. Intermittent short-acting nitrates as needed. Patient can clutch their little nitro tabs and feel comfortable with them. Take them as needed. Prophylactic long-acting nitrates are currently under question. Here's the problem. If you're on nitrates for more than a couple hours, you develop tolerance. In fact, you develop tolerance in a single day to nitroglycerin. They try to get patients who take nitroglycerin to take as few as possible, because then they're less likely to develop tolerance. The pharmacists say if somebody's taking longer acting nitroglycerin preparations, try to have them off the drug for at least 12 hours and overnight, say. They call it, give them a drug vacation. It means a different thing to pharmacists than it does to regular people. Drug vacation to a pharmacist means you're not taking the drugs. Make sure they take their primary anti-anginal drugs, beta blockers, etc. We talked about that. People with more severe disease will take triple therapy. That includes the nitrate, beta blocker, and calcium blocker. There are some novel drugs. Once the drugs stop working, then you're faced with PCI, and if that stops working, they come back to us again and we do open heart surgery. That's kind of the stepped approach. Now, what about anesthetic care? As I mentioned, you take the patient's history, You try to do your anesthetic. There's no one drug that's been shown to be superior. Anesthetic gases have some cardioprotective effects, so SIBO would be nice if you can give it. Make sure they take their medicines preoperatively and keep their heart rate slow. This is what I learned when I was a student. If you go in a pre-op holding, the patient's, I'm just going to make this up, the patient's blood pressure is 130/90 and their heart rate is 73. And they're not having angina. If I can take them back in the room and keep their blood pressure below 130/90 and heart rate below 73, I can be pretty sure they're not having angina. And that's what you need to do. So prevent tachycardia, make sure their blood pressure isn't swinging wildly up, making that heart cardiac demand more. The biggest issue will be, of course, as always at the end of the case, when you wake the patient up, their heart rate goes up. They're in pain, they're shivering, they're whatever. You're yelling at them. Raise your head off the bed. Take a deep breath. All those things we do. And it makes the patient's heart rate go up. If you have to give some Esmolol to keep the heart rate down, good idea. Labetalol, good idea. Anything you do to make their heart rate not be high, good idea. But otherwise, there's not one, magic bullet. Give 3 cc's of this drug and they'll be fine. We don't have any of that. You have to kind of take the whole picture and do what you can. Make sure they're hydrated so they're not tachycardic from that. Make sure our bladder's empty. If they need to pee and they hit PACU, they get tachycardic from full bladder. Nowadays you can ultrasound the bladder and see if they have a full one. A lot of PACUs are doing that. So those are the kind of the standard treatments. Okay, any questions? Good, well, then I'll see you next week.